Joining me is my awesome co-host, Dr. Juyeon Park. This is your monthly webinar held on the fourth Thursday of each month, and during these sessions, we strive to discuss some seminal papers that have actually significantly influenced our field, and we have one such paper today, and alternate these discussions with some technical aspects of metabolic surgery. In addition to these webinars, the Bariatric Surgical Training Committee also hosts a monthly Fellows Project covering key topics from your core curriculum. These sessions count towards the didactic requirements needed to obtain the FASMBS Bariatric Fellowship Completion Certificate. So next meeting is on May 2nd, and we will be discussing bone and muscle health. And also another reminder, don't forget to register for the annual meeting in Washington, D.C. So hope to see you guys there. Now, it's a true honor to introduce our distinguished guest, Dr. Vance Albaugh, tonight.
Don't give me that much credit, Faiz.
Dr. Albaugh is not only a highly skilled metabolic and bariatric surgeon, but also a physician scientist whose work bridges clinical excellence and cutting-edge research. He completed his MD at Penn State and surgical training at Vanderbilt, and was my co-fellow at Cleveland Clinic, at the Cleveland Clinic.
The Cleveland Clinic.
He now serves as an assistant professor of metabolic surgery at Pennington Biomedical and LSU. He's board certified in both surgery and obesity medicine. Dr. Albaugh also has a PhD. God, man, it's really long.
It's too many letters. Yeah.
He has done his PhD in metabolism and gut-brain signaling. His NIH-funded research is shaping the future of obesity and diabetes treatment, and through that, we can hope to get a deeper understanding of how the gut and the brain communicate. With over 100 publications, he's one of the few who can cut in the OR and cut through complex science with equal mastery. I came up with that. And we were just discussing all his work, and we hope to get you back, Dr. Albaugh. Our next speaker, I think Dr. Park is going to introduce. Dr. Park, do you want to take it?
So our fellow for today is Dr. Andy McKenzie. He earned his medical degree at Florida State University and did his general surgery residency over at Medical College of Georgia at Augusta University. And he's currently the Advanced GI MIS Bariatric Fellow at Vanderbilt University. And after his time in residency, he also got a master's of business administration. Wow, a lot of things. And now he is going to finish his fellowship, and he's planning on going back to his residency at Medical College of Georgia to do his academic career in bariatric foregut and general surgery. So Dr. McKenzie, please share your slides.
All right, thank you so much for the kind introduction. And thanks for allowing us to present this work. Really appreciate it. All right, can everyone see that now? All right, cool.
Good.
All right, so yes, we're here to talk about this recently published paper in obesity surgery. Total alimentary length is not associated with weight loss following proximal Roux-en-Y gastric bypass. So treatment response to metabolic and bariatric surgery, particularly Roux-en-Y gastric bypass, is highly variable. We know there are certain factors such as older age, higher BMI, and diabetes that are associated with less weight loss, but largely the variability we see with bariatric surgery is largely unexplained. We know there is a large, I keep saying variability, you'll hear it a lot, but there's a large variability in small bowel length. And so for proximal Roux-en-Y gastric bypass or traditional Roux-en-Y gastric bypass, the roux and biliary pancreatic limbs are only typically measured, and we don't really generally measure, or at least most people don't measure the common channel length in total alimentary length, or as a result, don't get the total alimentary length. And in terms of bowel length, there are, several different studies. They're all pretty similar. And of course, there's a normal distribution we see, but with that, there's a huge range in bowel lengths we see. In this study, 350 centimeters to over 10 meters in this case. There is some correlation with bowel length with male sex, and also height. Higher individuals tend to have longer bowel lengths. But other than those factors, there really hasn't been any evidence to explain the variation we see in bowel lengths. And I think, with talking about bowel lengths, I think it's helpful to kind of discuss the different types of bypasses or distalizations, some of the data behind that. So when we talk about proximal gastric bypass, we're talking about a traditional Roux-en-Y gastric bypass that, probably you're most commonly familiar with. In terms of distal bypass, this is a modification where there's either a very long roux limb or a very long biliary pancreatic limb length. And there's ongoing discussion today about, especially regards to revisional surgery in cases of inadequate weight loss and weight regain. Some of these could be used like limb lengthening procedures, sometimes commonly called, to achieve further goals of weight loss. And so with our type 1 distal gastric bypass or Sugarman distalization, we are increasing the biliopancreatic limb length, but leaving the roux limb fixed and the common channel fixed. And this gives a typical total alimentary length of 250 to 400 centimeters. Just kind of this schematic on the screen kind of shows a typical revisional case where essentially the BP limb is divided just proximal to the JJ and then hooked up downstream to lengthen the BP limb. And with the data associated with this, it is limited, but there's no randomized controlled trials, but it is associated with greater weight loss, but there's an increased risk of severe protein calorie malnutrition. And in limited case series, there's high rates of revision. There's a 43% revision rate in Dr. Sugarman's series due to protein calorie malnutrition, some hepatic failure and death associated with that. It was especially more problematic in the early part of this case series where the total alimentary length was very short, less than 300 centimeters. And then our type 2 distal gastric bypass, there's again a fixed BP limb length and a fixed common channel length, but the roux limb is allowed to vary tremendously. So the roux limb is very long as a result. There is a difference, of course, in theory and absorption there because there's only a small amount of the bowel where there's food products and bile and pancreatic enzymes meeting together. But the total alimentary length is essentially no different than a standard Roux-en-Y gastric bypass. But there is a lot more data on type 2 distalizations and type 2 gastric bypasses. There's a good randomized controlled trial, the Ducati trial, looked at the weight loss between proximal and type 2 distal Roux-en-Y gastric bypasses for a 5-year period. There was no difference at 12 months, 24 months. There started to be a small difference at 3 and 5 years, but this is really relatively small, 2.5%, 3.5% difference in weight loss at those time periods. Not much different than what we see with older individuals and higher BMI and diabetes. That small variation we see with gastric bypass, certainly not enough to explain the large variations we normally see with weight loss. But the study does suggest that common channel may have more effect on long-term weight loss or sustainability of weight loss. So just to kind of bring it back around, there was no prospective studies looking at association between weight loss and total alimentary length while allowing the common channel length to vary normally. The distalizations, they have a fixed common channel length, unlike a normal gastric bypass. There's a few other small studies that are difficult to interpret due to they're changing multiple bowel lengths at the same time, so it's kind of hard to know how that applies. There is, though, the longitudinal assessment of bariatric surgery study, a much larger study, not really looking at this particularly, but there was a subset where they did measure common channel length, and there was no association with common channel length and weight loss, though the biliopancreatic limb wasn't fixed in these cases. So it's hard to kind of interpret broadly. So our premise of the study was it was unclear how bowel length affected weight loss. We did suspect that total alimentary length did play a role. We know that the total bowel length varies tremendously based on multiple studies. And if we had a fixed biliopancreatic limb length and a fixed roux limb length, we'd expect a large variability in common channel length or total alimentary length. We hypothesized that this variability would help explain the weight loss variability observed clinically, and in some ways hoping that we'd find a direct relationship between total alimentary length and weight loss. So even by a 50 centimeter, 10 centimeter increment, we could see some changes that way. So this was an observational study. We measured the biliopancreatic, Roux, and common channel lengths for elective laparoscopic Roux-en-Y gastric bypasses. All patients were consented prospectively. Typical exclusion criteria, mainly people who've had previous bowel resections, previous metabolic or bariatric surgery, significant adhesions, making running the bowel difficult, and then significant medical disease where we worry about fluid shifts and things like that. In addition, patients who became pregnant during the study were also excluded from the study. And then we took weight loss measurements routinely to 24 months. And these were any data point we could capture within our system using REDCap. So anytime saw the primary care doctor, saw us, went to the ER and got a weight, we would have that data point entered into our system. And this study involved 4 different surgeons, primarily, all at a single institution, and largely performed laparoscopic Roux-en-Y gastric bypass. Similarly, there's a proximal gastric bypass, a 5-centimeter pouch over a 34 French gastric lavage tube, 50 centimeter BP, 100 to 150 centimeter Roux-en based on surgeon's preference. And then the total bowel length was measured from ligament detritus to cecum using standard March graspers. And we were able to enroll 329 patients in the study, and some were excluded just because of adhesions. We weren't able to successfully run them, but overall we were able to successfully measure 204 patients. And we had data points of those 157 of those patients at 6 months, down to 130 at 1 year, 89 at 18 months, and 83 at 24 months. Some of this, I should say, a lot of this follow-up was really due to the start of COVID that was starting to happen in 2020. So some of the follow-up was due to that, not coming to the institution to have weights. The mean age at the time of operation was 44.3 years, with a mean BMI of 46.9. And at some point, a few of the surgeons decided, let's see how long it takes to run the bowel. They started measuring, or having the circulator measure the time. And that, an average, added 2 minutes and 48 seconds to run the complete bowel, in addition to what normally is run. And here you can see very similar total bowel length to previous studies, range from 390 to 910, average of 592 centimeters. Alimentary length similarly very variable, range from 340 to 860 centimeters, a mean of 538. And most significantly, the common channel length was the most, obviously because the other 2 limbs are kind of fixed in length, the common channel is going to be the most variable. And that ranged from 190 centimeters to 730 centimeters, the mean of 407. And so we used weight loss modeling to identify a significant relationship between total alimentary length and weight loss. Our model is controlled for age, sex, height, baseline body weight, and the length of the roux limb. And there was no significant association between total alimentary length and common channel length. There was no change in respect to body weight, total percentage, or BMI total percentage. And essentially the study was terminated about 200 patients in when COVID was really ramping up, and really further follow-up would be difficult, and really we kind of answered the questions. There was no really, evidence to suggest a difference. And I think it's probably a little bit more helpful to look at the 2 charts on the right of the screen. This is the top right is percent body weight percent change, and the bottom right is percent body weight mass change. And although you could say, okay, this green line at the bottom here is lower than the other ones, just on a crude looking at a distance basis, but the shortest one is actually towards the top here. So there really wasn't any suggestion of a difference in terms of weight loss with alimentary length. So again, no detectable effects in this observational study on weight loss with variation of the common channel or total alimentary length for up to 2 years. And it suggests that the weight loss in the first 24 months depends on factors other than total alimentary length. And we did look at just some post hoc analysis and had the 10 shortest, the 10 longest, and there was no difference in weight loss, surprisingly, between the 2. Or unsurprisingly, given what we've seen so far, I should say. But not even a hint of suggestion. So some limitations, loss of follow-up, as previously mentioned. There's a small variability in roux limb lengths by surgeons, generally based on some kind of criteria of BMI. It was limited to 2 years. We don't know the longer term effects that maybe total alimentary length plays on weight loss. And we're unable to ethically test the reliability of the measurements either between surgeons or even as a surgeon individually. So now I will say that about 90% of these measurements were done by 2 surgeons. So I think there is still a lot of, at its core, should be limited variability, but we don't know. So. And here's some, I think I'll leave it over to Dr. Albaugh to kind of weigh in some kind of comments and questions to consider based on our discussion.
Thanks, Andy. That was great. That's a really great overview of a study that literally, had been ongoing for several years. It's a shame COVID kind of kiboshed it in a way. But even when COVID, was kind of ramping up, like you said, and we, I had left Vanderbilt at the time, or at the time I had already left Vanderbilt, but before I left, we kind of crudely looked at the data, and it really didn't seem like there was any difference. And that was kind of the impetus to continue getting measurements. I just have a few comments, and then we can open it up to the panelists, the rest of the panelists. I think this is a super interesting topic. And I think this is one of those things that really gets a lot of lip service, and people talk about it a lot. How long should we make the Roux limb? How long should we make this and that? Or how big is your pouch? Does that actually matter? And I think, scientifically, when you look at a lot of the data that's out there, there's really very little science to demonstrate, the right way to do these operations, or the wrong way necessarily. So, when we started thinking about doing this study, it was actually, I think in 2015, I think Rosenthal was the ASMBS president. And I remember sitting in a session at ASMBS, actually it was Obesity Week. It was still a joint meeting with the Obesity Society. And I was sitting in this section, and I sat down next to this guy with this silver hair, and it was a session on, I think, malabsorptive procedures. And, I sat down next to this guy. And of course, when the first paper came up for discussion, this guy gets up and goes right over to the mic. He starts, lecturing the people about how you're talking about 50 centimeter. It was a session on biliopancreatic diversion. And he was saying, well, your biliopancreatic diversion is 50 centimeters of common channel, and theirs is 150, and theirs is 300. And, the guy was Harvey Sugarman. So it was actually Harvey I didn't even realize who the guy was, because I was still a resident. And, I'm sitting there listening to him, and he made this big to-do about, we really need to figure this out, and we need to study this. And so Matt Spann, who's still in the faculty at Vanderbilt, we were there. The meeting was actually in Los Angeles, and we were talking about, this concept of this variability in the length. And Matt and I had this, like, what seemed like, kind of a crazy idea. And it was like, it'd really be fun to test this basically in this type of study. But, nobody's going to want to do that, because, there's this idea that it was going to take, 15, 20 minutes to measure all the bowel, and there were all these obstacles. And can you really do that? And is that safe? And would this be approved by an IRB? So I got to thank, we talked to Ronnie Clements. This is before Ronnie passed away, and while he was still clinically active, but he was a big proponent of us doing this, and he thought it was a great idea. And without his buy-in, and without Matt Spann, and then Matt convincing Wayne English and Brandon Williams at Vanderbilt to actually make these measurements, we would have never, ever been able to do anything like this. So I have to give them a real big shout out and a big thanks. This never would have happened without the support of a great team. So now that you've stopped sharing your slides, Andy, I'm going to go back to the slides.
Oh, it actually wasn't me. I'll reshare it.
But so I think that, like I said, I think this is one of those this is one of these things that we think a lot of these things matter, right? Well, if you're common channel, like Matt and I, when we were at ASMBS, we're like, surely people with like a 200 centimeter common channel must lose more weight than someone who's got like a 700 centimeter common channel. I mean, it has to be, right? It has to be, right? And so we're like, it shouldn't take like forever to figure that out. And so we were like, what we initially, and Andy and I had talked about this, last week. I said, what we thought was going to happen is that we were going to do this study, and we were going to do this on the first, like 20 or 30 people. And we were going to see this huge difference in body weight loss. And then we were going to stop and figure out where that point was. And we were going to do like a randomized study and show in 2 groups, common channel of this and common channel of that. That was the study that we were going to do. Well, we never, ever got to the point where we ever could show any kind of relationship of common channel to weight loss. And so, how much really does that matter? And I think you could have hour-long discussion or more with senior surgeons who would say, well, you know, these operations are quote unquote malabsorptive. But when you look at the scientific data, they're not really that malabsorptive. I mean, there may be a little bit of increased malabsorption over time, but they're not, that is not the main mechanism by how these operations cause weight loss, right? These are endocrine effects. These are GLP-1 incretin effects, central effects up here in the brain, not us forcing calories out of our GI tract and into the toilet. So Andy's got a bunch of questions here. You know, when I was a fellow at Cleveland, we did some distal gastric bypasses.
Right.
And I know a lot of people don't necessarily do those routinely, but I think that's something that as more and more people have gastric bypass, you know, people talk about it a lot more. And I think, you know, based on this study, you know, should we be doing, you know, a randomized trial on, you know, on revisional bariatric operations, and should we be able to try to pick this apart a little bit more?
So, Vance, my one question, I mean, I have quite a few, but the first question is, when you guys looked at this, was there a difference between, say, in terms of nutritional deficiencies that you noticed?
You know, that's a great question. And so that was some data that, you know, we have the weight loss data. And so one of the limiting factors with this being done at Vanderbilt, kind of in retrospect, is a lot of people came to Vanderbilt for their surgery, but they did not necessarily get all their postoperative care at Vanderbilt or within the Vanderbilt system. So a lot of the lab records get scanned in, and we have had some students over the years that have gone and done, you know, chart digging and diving and those sorts of things. And we haven't been able to get, you know, it's not 100% follow-up, but I want to say it's maybe 60% or 70% of the people that they've got vitamin levels, and the vitamin levels do not change. The people with those short common channels seem to do fine, and the people with those long common channels do fine. So that doesn't even seem to be driving micronutrient deficiencies, right? So that's why it's like, you know, you could say, well, maybe they're compensating in terms of calories and keeping the weight, or maybe they're able to compensate with one thing, but you know, compensating for micronutrient deficiencies is a little bit more difficult. And we don't see any differences between even those top 10 or top longest and top shortest. We don't see any differences in weight. You know, we haven't broken that up into micronutrient deficiencies, but we've looked at it about every single way you could, and we cannot, you know, for the life of us, show any kind of relationship between how long that alimentary limb is, you know, compare and the you know, whether or not people develop, you know, certain types of deficiencies.
So then the next question is, I mean, we have seen papers that say that type 1 distalization leads to more weight loss compared to type 2 distalization. How would you explain if the limb lengths don't matter, then why moving the Roux limb down and making the BP limb?
No, absolutely. And that's kind of the reason that we wanted to do the study in the first place, because there was this idea that, well, you know, we do a Sugarman distalization where we lengthen the BP limb. We do that and people lose weight. And I can tell you in my practice, I do a lot of those and people lose weight. But like, what's different about those people? It really gets you scratching your head. Like, is there something different biologically about these people that have gained the weight back after their primary or proximal gastric bypass? And when we do it to them, it makes a difference. But, you know, Sugarman and Brolin and those guys, they did these types of distalizations back in the 90s and late 80s. And they studied them reasonably well, I would say. And they, you know, people do not tolerate a type 1 distalization as a primary operation. Lots of people have issues with that, which kind of doesn't make sense based on the data that you have from this paper, right? Yeah. It's kind of weird.
So you're basically saying that if I have a 50 centimeter BP limb as opposed to 100 centimeter BP limb, it doesn't matter. Or the Roux limb, it really, based on your research, it doesn't matter what the limb lengths are.
Well, this, you know,
a critical point, like you can't make it smaller than this. And then obviously you don't want to go shorter than 70 centimeters in the Roux limb because of the bile reflux. But in terms of weight loss, does it really matter?
Yeah. So one of the limitations of this is one of the ways we were able to get this by the IRB as an observational study is we basically said, we're not going to change how we practice other than making the limb lengths. And so the people are going to get the same operation that they would have gotten. We're just going to know how much small intestine is there. And so what that allowed us to do is, sorry, I've got some noise in the background. Now, of course, now I'm drawing a blank.
It's okay. Take your time. We have enough time.
What was I going to say? Yeah, we were able to follow them, and now I forgot it. Now I forgot it, Faiz. What did you just ask me? Sorry, too many distractions.
Basically, is there a critical point?
Yeah. So that's the thing, right? In this study, we don't have a lot of people who have a total alimentary limb length of less than 400. We've got a couple at the short end. Okay, so that population of people who we would be doing a type 1 distalization that we would make at 400, those are just the tail end of our sample size here. So, and those people, they basically got a type 1 distal bypass as their primary operation. So then the question is, do those people ever regain the weight back? Or is that really the sweet spot? And it's not necessarily all the variability that makes much of a difference. But if you go below that 400, maybe then 50 or 60% of people really struggle. Like, is there, I mean, obviously there's if you give someone absolutely zero intestinal, real estate to absorb stuff, of course, they're not going to do good.
Right.
There must be a threshold somewhere. It's like managing as a general surgeon, you manage somebody with short gut. Like some people do really good with 150 centimeters. Some people do horrible with 150 centimeters, right? And it's like, we want to say that's all due to, well, they have an IC valve or they've got part of their colon and maybe that has something to do with it. But there's probably a lot of other things that we just are completely oblivious to.
Great. So we just have a poll that just popped up. Please do answer this. It'll help us in our discussion today. So
Faiz, what do you do in your practice?
I do what we did at Cleveland Clinic.
What does that mean, Faiz? We don't know what that means.
Okay.
Yeah. What do you do, Juyeon? Well, how long do you make your limbs?
Yeah.
For me, so in my training at University of Tennessee, our Roux limb was 60. Oh wait, no, sorry. Our Roux limb was 150. Our BP limb was 60.
And that's just what you did every time.
That's what we did every time. So one of our attendings would sometimes make the BP limb 80, depending on random factors of the day. But otherwise, it was 60 and 150.
And Faiz, what do you do?
I do the 100 and 120, and then the BMI is, so basically what I've done is in my practice, I'm moving away from bypasses and going more towards the SADI procedures. So if they're BMI greater than 50 to 50, especially 55, I lean towards bypass SADIs, even if they have acid reflux.
Yeah.
And then obviously you have the whole discussion whether if it changes, I'll convert this and all that. But yeah. So I'm thinking, and my partners I know do 50 and 150. And you're right. We kind of have this, like when we look at our data, and we do have long-term kind of follow-up data, the weight loss is pretty similar.
Yeah, one of my colleagues also does like 150, and I'm like, that's a lot.
Right. So let's look at the poll result. Sorry, this is something a little new for us. I am going to try and see if I can.
And I know there's fellows on the call, so even if you're a fellow, you can answer with what your program does.
Yeah.
And if you're a fellow, tomorrow morning, you should ask your attendings why the heck they make their limbs how long. Because you will find that's just what we did in fellowship, or that's just how I was trained. I mean, there's really not, there's a too short of a Roux limb. We kind of know that from bowel reflux, like you kind of mentioned, Faiz. Like you never want to go less than 75. Which I think most people go at least 100, 150 nowadays. But for the rest of the limbs, Yeah.
I have actually had to take patients back for bile reflux, and then you make the Roux limb longer. And because, they come back with acid reflux, and when you actually do a Bravo probe, they don't have acid reflux. What they have is bile reflux, and you can actually see, and some of the patients, I can go all the way down to the JJ. So you can imagine how short that is, right? So I've seen this, and that it kind of makes you, scratch your head as to what is the length. I mean, do we know this? And like the results after distalization procedures is so variable. I have a patient who lost 20 pounds, and I have a patient who lost 60 pounds. I don't know how to make sense of it.
Right. Yeah. So then we say, well, they must not have done they must have just ate the wrong things.
Right.
They must not have been as active. I mean, but we have all these other scientific studies showing that there's this tremendous variability in response to a lot of things. And is it just genetics or some kind of biology that we don't understand? I feel like as surgeons, we want to, you hear a lot of surgeons talk about, I make a small pouch so my patients lose a lot of weight. I mean, that makes no sense based on the science, right?
Right.
So there are some downsides to making a big pouch, but they're not necessarily, I think, weight gain or not weight loss, but
again, this is my theory because before when I joined this practice, right, our previous surgeon used to make those pouches like really small. You could almost call them like a mini pouch, right? But I feel like patients, when I go and scope them back, the GJ is dilated, so your pouch is not really serving as a reservoir. So there is danger of making the pouch too small. Now, is there science behind that? And does that dilate over time? And now you can eat a little bit more. I don't know. I mean, do we know of any studies that actually look at that?
Well, I think there's a scientist who was at the clinic with us, Faiz, Roman Van Goitsehoven. And so Roman's done some great studies where they actually put probes down and they've measured gastric emptying after gastric bypass, after sleeve, and in normal people. And his studies, along with a lot of other folks, when you have bariatric surgery, it lets the food in faster. Like when you measure it. Now, of course, this is like liquid stuff. This isn't solids, which is probably a little different. But when you drink liquids, things move very quickly from the foregut down. But the interesting thing is that if you look at sleeve and bypass, sleeve patients tend to have a higher, you could say, time that things are spent in the intestine, whereas things move much quicker through the gastric bypass through the rest of the intestine. So like, what does that mean? What is regulating that? I mean, we really don't know. But this idea that like things just don't get in, like they somehow stay stuck in the pouch, right? When I explain to my patients, I say the pouch is like a coffee cup, but the coffee cup has no bottom. Right. I mean, you just pour the liquid in and it's going to go right in.
I mean, and that's why I tell my patients, and I would recommend the fellows to do that, because people do adapt to after bariatric surgery the way they eat. So my recommendation is whatever you can eat in 15 minutes is all you get to eat. You can't sit there with your plate for half an hour. Eventually, you'll be able to eat a whole sandwich in an hour's time.
Yeah.
So just make sure whatever you eat only in 15 minutes kind of thing. And the other interesting thing I've seen is like when you scope a sleeve patients, up to the esophagus, you see the nice little peristalsis happening. But the moment you go into the sleeve, you see no peristalsis. So clearly things are either going through fast, and maybe that affects the motility, because we know, back in the day, people would say it's restrictive versus malabsorptive. We know that is not true.
Right.
Okay. James, you had the poll up. I would love to see what the poll had to say. I mean, I saw the first question, no one actually measures the ball length. And I know people, what would you advocate for that? Like, instead of doing this 50, 150, like we come up with a percentage. So if you have 9 centimeters, 9 meters of ball, then common channel should be like,
I think a bunch of people need to get together and study it. I think you got to do a study, and because I think it either matters or it doesn't matter. So I think if you measured a bunch of people, and you don't want to make those measurements for nothing, right? So you could do, people could start doing a percentage of total bowel length or a set BP limb. But like, we all have to get together, and like somebody's got to decide to put a group together to actually study this in more of a controlled manner so we can try to figure it out. And based on this study, I think, this variability really isn't a factor that drives a lot of the weight loss, but maybe it is only in this group of people who are at the lower end. Maybe there is some sort of threshold there. That's probably where the next studies, and if that's a revisional, RYGB revision, in terms of total alimentary limb length, maybe that's the next step. I think, some smart people need to get together and like figure it out, because it doesn't make sense for us all to start measuring it if we're not going to do anything with the data, right?
Absolutely. Like we don't know what the length should be. And then, like you said, does it matter? Is there a BMI, like a lower BMI, you go with this, higher BMI, you do something different? Now,
Right.
the other question I had was like, there is a group of bariatric surgeons, and you have heard that at FASMBS, where a lot of they're converting the bypasses to say these are DSs. What's your opinion on that? And why does it lead to better weight loss than say
You
a
know,
little
I
bit
think
more consistent weight loss than say distalization procedures?
I've never seen super great data comparing both the procedures. I know there's some data that's out there, but I think if you compare a gastric bypass with a SADI, that's not a fair comparison. I think we really need to have a trial where we compare distal bypass, type 1 distal bypass with SADI. In my practice, if I have somebody who's got reflux and they, I'm not going to do a SADI in them, I'm going to do a distal bypass. And that might be my primary procedure. I might go in and do a total alimentary limb length, 400 centimeters distal bypass because I want to, decompress their stomach and fix their reflux. Whereas I know some people would do a SADI in those or a BPD. I like the gastric bypass, for the reflux control, but I think we need to study it better. I think we need better data.
You're
data
talking about
collection.
after a sleep, if they had reflux, you would go for a bypass.
Yes. Yeah. Or if I have somebody who has a lot of weight to lose and they have reflux, I'm going to do a distal for my first procedure. I'm going to go right to a distal gastric bypass because I think that's probably, better in terms of weight loss.
So define distal for you.
Distal is a 400 centimeters of total alimentary limb length. So
So
I will go in on those patients and I will measure the whole bowel and I will make my TALL 400 centimeters.
What would be your rule in those circumstances? Like 150?
120.
120, and then the rest would be this one.
And then like what is that, 3 or 280 of common channel?
See, I have a little bit of a different take on that, Vance. I feel like converting a SADI or a SADI procedure to a bypass is a little bit easier than going the other way around. So I asked them, like, what is bothering you the most? Is it your weight? Because if you have someone with BMI 50, and if I'm giving after a sleep, I'm talking about these are all revisional procedures, right? If you're going to convert that to a bypass, I mean, you're going to really struggle to come down below 40 in terms of BMI.
Right.
So I say, listen, your reflux may stay the same, but it won't get worse. Like we know that, right? With SADIs, your reflux is not going to get worse. So convert that to a SADI and see where they end up. And if there's a hiatal hernia, fix the hiatal hernia at that point. And, see how we go. But obviously, I haven't been in practice that long to see these patients back and see if I have to convert the SADIs to bypasses yet. I've had to convert a SADI to a bypass for my partners, my senior partners who retired patient, but not super hard procedures to do.
Yeah. I've never converted it. If I had somebody with a SADI, I wouldn't be converted into a bypass necessarily. I agree with you there, Faiz. Yeah. I usually reserve the SADI in my population that I serve, to operate on. I generally reserve the SADI for like a weight regain after a weight recurrence after a sleeve, which is probably similar to what you're talking about too. But yeah. But this is good. This data here. This is
right. Like look at that variability right there. 35 to 200. Wow.
So then the next question would be, how do you measure it, right? So in we got a lot of slack from the reviewers of this paper because the reviewers were like, how can you ensure that, you don't have no data saying that these surgeons, did this the right way? Maybe they were all over the place. But like Andy said, two of the surgeons did like 96% of the measurements. And so when you look at the distribution of each one of those surgeons, I mean, they basically fall right on top of one another. They've each got about 100 patients. And so we felt pretty good about it because, using the marked graspers was, again, part of what the standard practice was at Bandy at the time. And it probably still is, I imagine. And so they're already in the sets. It was like path of least resistance. I've got some current partners now that like to use an umbilical tape because they feel like it's more accurate. But then I tell them about this study and I go, if you're off by 10 or 20 centimeters, it's probably not that big of a deal.
No, I mean, I actually am an advocate for umbilical tape for multiple reasons because one, the counting becomes easier. Like you just have to remember one number, like, you cut the tape for 25 centimeters, especially if I'm doing a SADI. But again, with that, it depends on how much bowel you're stretching.
Right, right. That's true.
Like,
That's very
if I
true.
just laid down there versus I'm stretching the bar, like I don't think we can ever, personally, I don't think we can ever kind of measure your 100 centimeters will definitely be variable than my 100 centimeters. So yeah, this is interesting. 200 centimeters. I actually want to know from our audience who does a 200 centimeter BP limb.
That's almost like a one anastomosis gastric bypass, right?
Right, right.
Yeah,
I thought 150 was long. 200 is very long.
yeah.
Yeah. Do you want to identify yourself and maybe we can questions? No?
No.
But I will say people do well. I mean, I've done distal bypasses where I've left people with 400 and 500 centimeter BP limbs, right?
The revisional procedure.
As a revisional, right? Because I'm going in and I'm counting. And to give them 400 of TALL, and I'm putting it all on the BP limb, right? And those people do good. They do fine, right?
Now, you would think like TLL should be different for patients with different height, wouldn't you? Like if you're looking at the percentage, why does 400 centimeter have to be for 6'3" per height person
Yeah, that's
versus
a good question. That's a good question, Faiz. I don't know the answer to that.
there's a lot we don't know. I know. It's like with revision too, right? You don't know, do you go aggressive and give them the weight loss, and then if they have malabsorption, then we come back and fix it because insurance is a problem. Like a person, who actually Fulan Ayula was the person who kind of mentioned this to me. He said, if you are aggressive and the patient ends up with malabsorption, people are going to fault you as a surgeon, but the patient benefits with the weight loss. And you can always go back and revise that procedure. But if you are someone who was playing safe, because I was really playing safe with my DS,
Right.
then everyone's going to blame the patient that they got DS and still didn't lose weight. And those words still echo in my head.
There you go.
Right. Juyeon, I don't want to hog Vance's time here. If you have any.
No, I want to ask Andy, do you have any other questions? You've been quiet for a little bit. I'll let you have
Andy, how long are you going to make your limbs?
I'd probably just want to stick 50 to 75 centimeter BP and 100, 150 Roux limb, pretty standard.
Yeah.
It's like the more I learn, the more I get confused, or get it's
right?
like
absolutely.
It's all simple, and then you learn more, and you're like, it's
not simple.
Nothing's answered.
Absolutely.
So
absolutely.
Vance, since no one else is asking questions, I'm going to keep asking. You know me, I always ask. Vance used to be the guy I always went there and asked questions. Like he used to be in the other office and I was with the other office.
It's good we weren't in the same office. We'd never get anything done because all you would do is ask questions.
And I was with Josh Winder, and Josh is the quietest guy. He's at Penn State right now, and he was the quietest guy. And no matter how much I tried to talk to him, it was like very monosyllable answers, but then Vance and I would go back and forth. Vance, now, are you there?
Yeah, I'm here. I'm just looking at the chat. I see Shane Ackhouse made a good point, and she's absolutely right. You should never see bile in the pouch.
Yes.
Bypass, right? That's one of those reasons. Yeah, for the fellows, not to make a short Roux limb, you need to have at least 75, and I make mine all probably at least 100 to 150.
Yeah. And that brings up, because, if you look at my old partner's notes, he would document that he made his Roux limb 120 centimeters. But again, brings us to the point, like, are you actually measuring the right way or not?
Or does it change over time, right? I mean, is there some, variability and, as people lose weight, is there an adaptation of some sort? I mean, most of us, if you take trauma call, or most of us, I remember seeing this in residency when I was on the trauma service, you'd lap somebody for like a spleen and you'd lap them and it'd be like, oh, they've had a gastric bypass. And when you pick up that Roux limb, clearly that Roux limb's heavy. I mean, it's much heavier than the rest of the bowel. So there's clearly some sort of adaptation over time. And, Anita Corkelis at Pitt and Nick Stylopoulos at Boston Children's, they've done a lot of work showing in people, even, 6 months, 12 months out, there's definitely a hypertrophy and a changing of the intestine. Is there any growth over time? Is that why some people who gain the weight back after gastric bypass and you do a distal bypass, does it, is that is there some sort of mechanism there? I don't know. But
I don't know. I mean, I know you're doing this research with micronutrients and kind of maybe after that we will have some more idea, because another thing that makes me a little perplexed is that some patients after bariatric surgery adapt healthier eating habits, even though previously they did not have that. Like you can hear them, they're like all about proteins and eating healthy.
Right.
And then some lean towards carbs because that's the only thing that they can tolerate. Now, I'm saying let's omit all those people who have reflux. Maybe that's a different category. But why is that? Like some people after bypass can adapt more to the carbs and don't get dumping, but others do if they eat more, sugar-loaded food.
Yeah, right. There's probably just some variability. It's like some people who have a gastric bypass and they think about eating a cookie and they dump, right? Whereas other people can eat a few cookies, right? I mean, it's like there's this there's this variability that we really, we have recommendations as their surgeon or their physician, but clearly people are, I mean, it's like that in most everything, right? So we don't understand the variability, right? That's, NIH has this big program now, the All of Us research study, where they're trying to understand the variability in disease status and treatment response. And this is that same sort of thing. Like, why is it that, diabetics lose a little bit less weight after a gastric bypass? And there's some ideas, but it's hard to test those, right? But clearly there's variability there. There's variability in, why do people have, one of the kind of interesting things from all these small bowel studies is why is there such variability in the small bowel length, right? Everybody's got about the same length esophagus. Everybody has got about, I'm sure, Andy, you've probably seen Brandon Williams blow the stomach up after a sleeve. And it's always, when you submerge it in water and you look at the displacement, he looked at a whole bunch of those. They're all about the same size, right? Everybody's colon is about the same size, right? Colorectal surgeons, when they're doing endoscopies, they don't say, oh, there's a really tall guy here, I better get my extra long endoscope out because I expect it to be like a foot longer. I mean, that doesn't happen. But so the rest of the GI tract does not have this variability, but the small bowel has a tremendous amount of variability. And really, like Andy said in the presentation, the only thing that really, is related to that variability is height for the most part. And if you look at if you control for height, sex goes away. And that's just because men typically are taller than women, right? So, but if you control for sex, if you control for height, there is no effect on sex. So like really tall people have more bowel than really short people. But like, what does that mean? I don't know. Like,
no. I know you've done a lot of research on bile acid absorption and everything else. Have you seen any differences like that can account for this variability? Is there a differences, or is everyone's absorption? I mean,
it's probably different, but it's it's so challenging to measure these things.
Like dissect it out.
Yeah, I mean, it's just very difficult, right? I mean, it's very difficult and very expensive. And then a lot of these things, there are. I'll say, there are interesting questions, but do they really make a difference in the management of the patients? And that's the thing when you're writing, if you're writing a grant, whether it's to NIH or Department of Defense, like they want, how is this going to improve, health? And unless you can make that jump, it's very difficult for them. There's a lot of interesting things that we do in surgery that you could, if you had an institute that only wanted to fund surgical projects, we'd have all sorts of interesting projects, but they're not necessarily going to make a huge impact on human health overall, right? So so like a lot of these things that we do, no one's ever going to study them because it's hard to make that connection to a group that's got a lot of money to be able to say, hey, you give me this money, and if we figure this out, it's going to make a huge difference, internationally. I mean, all these sorts of little technical things, it'd be really cool to study them, right? But like, you got to have some data to show that it's actually going to make a difference. And so again, the variability, there's so much variability in everything. It does make it very challenging as a scientist to kind of, where do you kind of, put your balls and figure out where do you want to pull out all the marbles, basically. Yeah.
I feel like you guys brainstormed about like 5 different projects we could make.
Yeah, right.
Just this talk. And it's just like, what is the limiting factor for any of those projects to actually happen?
Right.
Is it funding or what is it?
Right. I'll tell you, this study, like I said at the beginning, this study, I mean, we got real buy-in from Brandon Williams and Wayne English. I mean, those guys, I mean, we didn't know initially, but like Andy showed, it didn't take that long to measure the bowel. It was actually pretty short. So it only took, what was it, Andy, like 2 minutes and 40 seconds?
That's right.
Extra, right? So, I mean, like most people are like, oh, that's got to take, 15 minutes to do that. Did not. It was actually relatively quick, which is good in a way because Now it's kind of like, well, you know what, maybe we could do this, or maybe we could, do a study where we look at this a little bit more in depth, because that barrier has kind of been, brought down a little bit. So
True. So now we a majority of our audience is fellows.
right.
So we don't want to leave them confused. Now, if I am a patient, I had bypass, doctor, 15 years ago, and I had great weight loss immediately after. But then I don't know, in the last 5 years, I've gained like 60, 70 pounds, and I really want to lose this because I felt so great being at that weight. How would you take me through this? Like, what would Dr. Albaugh recommend for me?
I'll tell you what, Dr. Albaugh at Metamore, what we would do is everybody gets plugged in, whether they're primary or revisional patient, they all get plugged in with obesity medicine. Okay. They all get the diet. I mean, they get all this stuff, right? And they get all the re-education. But, if I've got somebody, I've got actually a distalization coming up, I think next week or the week after. And, in most of the patients that I consider a distal bypass, I tell them, and this is probably the important thing for the fellows, I explain to them what kind of bypass they had. And if it's 10 or 15 years ago, they probably don't have the op notes, and I don't have that. So I say, you probably had this limb length was this, and this was that. And there's probably a lot of bowel down here. And what we're going to do is we're going to take this connection and we're just going to move it down, and we're going to bypass a little bit further, which all the patients then say, oh, so I can't absorb things. And I go, well, not really. That's probably not, there's probably something else. It's not that. But what I always tell the patients, though, before we go to the OR, and I write it on the consent, I say, there's a possibility, and I've had this happen a couple of times, where you take a patient for a distalization, and they're one of these people that had 400 centimeters of total alimentary limb length, or they only have 300 centimeters of TALL, and I'm not going to make it. I don't make it go any further, because I feel like that's playing with fire. Are you going to push them over the limit? Maybe they'll get really great weight loss, but maybe they'll have protein calorie malnutrition, bile acid wasting. Am I going to put them into liver failure? Who knows, right? We don't know enough. So I always say, when I'm going to take someone for a distalization, hey, if we get in there and you've already kind of had that, and there's no way of us knowing that up front, but if we get into the OR and it's, or if I'm going to move it like 20 centimeters or 50 centimeters, I don't bother with that, because I think that's not worth the risk, right?
Now, if you could give me like you could give me a decent what would be a decent distalization for you, like 100 centimeters? Oh,
I make the total alimentary limb length about 400.
No, but I mean to say, like, if the tall before was like, say 600, 500.
Yeah.
Going down to 400, you would offer that? Oh, you would do that in the OR?
That's what I do. I take them down to 400. And I have had patients. I had a lady, I was probably 6 months into practice, and I did a distalization in a lady, and that was the lady I gave she had like 650 centimeters or something in her BP limb. She had so much bowel, right? So much bowel. And I gave her 400 of TALL. She did very well. She lost a ton of weight. But I've had other people who come in and, maybe their BMI is 35, 40, and you take them and they only have 300 centimeters of common channel, right? And they got about 100 centimeter roux limb. And I don't do anything. I kind of abort at that point in the operating room. Yeah. Okay.
So then when you counsel them about weight loss, do you give them a number, or say, at this point, we don't know what?
That's a great question, because all this revisional stuff, we don't know, right? You don't even really know, we know that, if you have a sleeve done, the 10-year data from FASMBS and the Ozenberg trial, right? Your 10-year weight loss for a sleeve is about 20-ish%. Your 10-year weight loss for a bypass is 30 to 35%, right? So I anticipate that we're going to be doing more and more bypasses and less sleeves over the next several years, because I think there's a couple clinical trials that have essentially, corroborated those findings. But then the question then is now that we'll have if we have more people who have gastric bypass, and if they regain the weight, if there's weight recurrence there, then, and what
do we do?
Yeah, then what do we do, right? I mean, right now, most of the data says do a type 1 distalization. Don't go below 400 centimeters of total alimentary limb length. But there's data for that, but it's not like I don't think anybody's done a randomized, controlled trial, right? It's hard to do those in surgery. So our data is many times limited to what we've got. But the best clinical evidence that's out there says if you go below TALL of 400, you could be getting into some situations that you don't want to be in terms of protein calorie malnutrition, diarrhea, things like that. Yeah.
Good. So then the other question for you is like, if you have done a distalization type 1, now, first, for your normal bypasses, how often do you check vitamins? And would that change for after a revision?
Yeah, I treat all my distalizations or my distal bypasses, I treat them just like a SATI, just like a BPD, just like we'll say, we call them the malabsorptive operations.
Yeah.
Which it may not be as much malabsorption as we think, but clearly those people seem to be a bit more high risk for developing micronutrient deficiencies relative to a regular sleeve or a proximal bypass. But we generally check vitamins for those procedures, 3 months, 6 months, and then a year. And then if someone's symptomatic, if somebody's complaining of a little bit of, night blindness or something, or if there's anything weird, we're checking a thiamine, a vitamin A, copper, zinc, unexplained rashes, things like that. We try to keep on top of those. But yeah, that's kind of what our.
But then the frequency, does it change for you? Because for my bypasses, I do it at 6 months and then a year and then yearly afterwards.
Yeah, we do one more check. We do one more check at 3 months. So early on, we make sure that they're not. So we check some labs at 3 months.
For your revisional cases,
or the distal, anything that's the distal or the BPD or something like I'll say the malabsorptive stuff. We check 3 months, 6 months, then 12 months, and then it's really how is the patient doing? Are they following the instructions? Are they taking their vitamins? We try to keep close follow-up. Of course, all of our follow-up, everybody on this call, everybody in the United States, no one's follow-up is great. We know even when you look at MBSA QIP, what is their 1 year follow-up, like 20%? I mean, that's pathetic. So, but it's hard after a year. It's very difficult. I mean, and this is not a secret in our field. It's very difficult to have a very good follow-up rate once you get 2, 3, 4 years out. The problem is people don't have the medical issues. They're not having a problem with the operation. Most people do really well. And so they're like, why do I need to go back to the surgeon, right?
True. So
yeah.
What I say is I give them a card, like all the vitamins. I said, I don't care if you don't see me. You can always kind of, say hi to me socially and all that. But make sure someone is checking these vitamins every year. You can never say. And I think that's something that the fellows need to understand. Like when you're in practice, make sure, and I think it's a moral obligation for us to kind of, make sure that they understand that they have to check vitamins and have to take vitamins for the rest of their life. I said the only actually 2 contraindications I have in my practice. One, if they have suicidal risk, I'm not taking them on. And the second one is if they say, oh, I don't think I can do vitamins, maybe I'll give them a sleeve.
Yeah.
Like it's always a balance. I think
right. Oh, absolutely.
Individually, you're not going to you see someone who has maladaptive eating habits, you're not going to do a whole lot. They need a different kind of treatment.
Right.
Yeah.
I have one last question to ask. Just because you have the DABOM certificate, do you bring that up a lot more with a lot of the obesity medicine talks with your revisional cases that you're thinking about? Like, do you bring up medication before you talk about any of these like distalizations and all that stuff at this point?
For some of the folks, anybody I see who's had a gastric bypass, I always work them up for a gastric fistula. And if that's the issue, we'll fix that. But, I will say many, not all, but many of the folks who come in for a distalization, they're usually, I'll say, of course, this is very anecdotal. A lot of them are kind of BMI in the high 30s, low 40s. They're not like BMI 70, 80 people. Now I have had people who have had bypasses and they come back after their bypass and their BMI is 70 or 80.
Yeah.
I think something's different there. But I generally talk about the meds with all my patients. I do not prescribe them in the clinic setup where I am. I'm essentially like contracted out as a surgeon. So I'm not really paid to be an obesity medicine doctor. I have the certification. I talked about, it's part of the options. It's part of the informed consent essentially. And so my patients know that I'm a big proponent of them, but there's one of the other obesity medicine doctors that's in our multidisciplinary clinic that takes care of that. But for some of the patients who are the BMIs like 35 and they are like, yeah, I want to get down to the 20s. Well, maybe you want to get there with medications. And a lot of times, if they got brittle diabetes or if they've got, something where they can get access to the GLP-1s, I'm like, that might be the better way to do it. And then I always tell them, you know, we may go to the OR and maybe you've already kind of exhausted that and we don't know. So there's some risk there without any real benefit. So I always have that discussion, and I am a big proponent for, you know, we need to work with the medical doctors. I think it's a synergistic relationship. I mean, lots of people are very open to medicine and lots of people are not open to surgery. And I think part of in our clinic, the way we approach it is people come in and they want the medicine and they get educated about what surgery is and what it means. And that is a huge, they're like, oh, you mean so I can still go to a restaurant or I can still go to eat with my family? It's like, yes, you can. I mean, there's so much misinformation. And so it's the education, I think, that really is, you know, necessary.
100%. So that's something that we have done at our program in terms of like when we see our patients. I do prescribe medications and I only stick to GLP-1s. I do not like the other ones because I really think that's just too much work for the results you get. But like Vance said, I think it's the education part that they don't get. And I feel like, you know, when they come and they have all these myths and notions that, oh my God, I'm going to eat like a bird. I mean, I love my food too much. And when someone says, oh, I love my food too much, I don't know what to do about that. Then you're going to say like, that's the signaling. That's the kind of thing that's happening. The food noise is what's the problem. And once that food noise goes away, how do you think you'll feel? Do you feel like you're going to eat like that? So the education part is going to be different. And I'm a big advocate for getting the board certification for obesity medicine. I'm going to be taking it this year. So Vance, I'm going to be calling you again and again. But yeah, and with that, I think our hour is up. Can you believe that? It's over.
I will say, hey, Faiz, with the obesity medicine, you know, as a surgeon, I think, oh, what's her name? She's in Colorado now, but she used to be in New Orleans. Rachel Moore.
Yeah.
Rachel made a comment once and she said, it's not her whole practice, but she made the quote. She said, it feels like it makes me a better surgeon. And I think I feel the same way. I feel like you're able to talk about things and really connect with your patients. So I would encourage all surgeons to do it. It's not that the test is not that difficult. It's a lot of surgery on the exam. And a lot of things that you probably already know and you don't realize.
I've heard otherwise, Vance. I've heard otherwise.
Well, and then there's a lot of pediatric
study
stuff.
For that is what they said. You can't just go and take this test. So
like chemistry and everything.
I know. I heard there is like someone took it 2 or 3 times and couldn't make it. So
I think our last 3 or 4 fellows have all gotten their certification during their fellowship with us. So we have a program where we have a CME review course where they, you know, are eligible. So, and they've all passed with flying colors. So it's not anything that is too much for any surgeon that's doing this already. 100%.
That's awesome. Very heartening to know. And with that, I think we will end. Thank you guys. Thank you for coming.
Great.
This was a very engaging and enlightening webinar. So join us next time and we'll see you guys